All right. Hey, everyone. Hope you all are doing well and staying safe. Thank you for joining us tonight for our webinar on clinical needs in IR with Dr. Navuluri. It's an honor to have him talk to us today, but before we get started, I just want to share a bit about what the Biodesign and Innovation Committee is currently working on. So as you may know, that tonight's webinar is the second of a 5-part biodesign webinar series, where speakers will be talking more about the different steps in the biodesign process, from identifying a clinical need and developing a concept to entrepreneurship and bringing this idea to market. One initiative we're running in conjunction with the series is a survey to assess its impact on medical student education and understanding of the biodesign process. We'd appreciate it if you could fill out this short survey that you received from Hudson earlier today, or if not, you can scan the QR code on the screen right now. Thank you so much for helping us with this initiative. So this webinar series also runs in conjunction with our committee's flagship project, the Biodesign Competition. Our theme this year is innovation in the era of COVID-19. We invite teams of medical students, undergrads, and other graduate students to tackle these challenges and clinical needs that IR physicians face during this pandemic. You can scan this QR code to sign up for the competition or simply learn more about what the competition is all about. And this Biodesign webinar series is designed to run alongside the competition to provide teams with any practical information about the biodesign process to inform your journey through the competition. And you can learn more about this process on our Biodesign Center page on the RFS website. All right, and that's my quick plug for our committee's work. Now it's my great pleasure to introduce you all to Dr. Navuluri. Dr. Navuluri is an associate professor of vascular and interventional radiology at the University of Chicago. He's also the director of the vascular and interventional radiology residency program at UChicago, and his clinical interests include women's health, men's health, and interventional oncology. So without further ado, let's give a warm welcome to Dr. Navuluri.
All right. Thanks so much for the introduction. And I will defer to the host to let me know if my audio or video isn't really showing up properly. So first off, I really want to thank SIR RFS for inviting me to speak. It's both an honor and also a little bit nerve-wracking of all things to speak on this topic, because it's certainly not something that I'm an expert in. But I'd like to, break down today's, webinar or discussion into kind of 2 parts. We want to spend a few minutes kind of on identifying clinical needs and how that fits into the more formal biodesign process. But hopefully the bulk of the time I actually would like to just discuss with you guys and maybe help you guys out, because I suspect many people who are on this webinar are interested in participating in the competition this year. Or maybe even if you're not, maybe you have grander designs and you want to engage in a biodesign project for yourself in the future that's IR related. And so I'm hoping that maybe I can help you out a little bit with input, not necessarily as a biodesign expert, but someone who's been a practicing interventional radiologist for 11 or so years now. Hopefully we can do that either through live discussion if the mics can be unmuted, or we'll just do it through the chat discussion. So I have no disclosures other than, I guess, sort of what I just said already. So traditionally, interesting discoveries, are made, and then people would look for ways or problems that they could apply those, those discoveries, or they look for problems that those discoveries could address. As you guys, probably know from the first webinar, the biodesign innovation process sort of flips everything upside down. It's a process that was first developed at Stanford around the turn of the millennia, and it's really needs driven. And what that means is that there's an emphasis on identifying and creating a in detailing a clinical unmet need, rather than sort of fitting an existing solution to a need that's that already exists. So it's, I apologize, I'm not phrasing that right, but basically you want to find a problem first and try to fix it, as opposed to stumbling upon a solution and trying to apply it to an existing problem. So there's 3 phases, and these have probably already been discussed on prior webinars, but the ones we're going to focus on are the identify phase, and that can be broken up into 2 stages, needs finding and needs screening. Again, I'm not really necessarily an expert by any means. I haven't done the Stanford Biodesign Fellowship. I know a little bit about it, so I'm kind of going to talk about it right now, but I'm just going to try to give the broad overviews and see if I can apply that to your guys' hopefully future project. Again, I'm not going to go into granular detail, but we are going to touch on both, the needs finding aspect, as well as the needs screening. And the important thing to remember is that the needs statement is sort of the foundation of both of those stages, and it encompasses, the entire phase. The needs statement is essentially a mission statement, and to put it in words, the idea is to succinctly state an unmet problem in a particular population, as well as the desired outcome of that project. So you want to be able to establish what your need statement is before you proceed to the next step in the biodesign algorithm or process. So an analogy I tried coming up with was sort of, making the perfect water balloon. So if you want to get in a water balloon fight, you might think of, this little girl terrorizing you. That's sort of the problem. The population you're trying to help is, yourself, who's getting pummeled with water balloons, and the outcome may be making multiple balloons on your own that's going to be able to fight the battle. So again, to go through the need statement, there's 3 aspects of it that were underlined in the previous slide. So you need to identify the problem, the population to address, as well as the outcome or the goal that you expect to see. So in this particular scenario, COVID and IR has sort of already been the problem that's been assigned for this year's theme. But within that broad theme, there's multiple areas that you guys can figure out specific problems to solve. So if I had to distill down this talk, or what we're going to talk about for the rest of the evening, it's that identifying the clinical need, that is the problem. That's the first and most important step really in the entire journey. Because without identifying the problem, you can't invent the technology that's uniquely designed to solve that challenge. And the other take-home point when you identify a problem is that you really want to make yourself an expert in that particular problem. You want to make yourself an expert in that particular area of need. So again, once you identify the problem, it's going to help to narrow your focus. And in a perfect world, maybe you'll figure out a problem that affects all of IR, and maybe you're going to solve some great big, a dilemma in IR and COVID in one fell swoop. But more likely, you're going to have to focus your problem to a specific population, and you can stratify your population based on a number of different categories. It can either be by disease, so maybe you can focus on dialysis population within the IR among the IR patients. It can be an IO or an oncology population, PAD. There's so many areas within IR, since IR does encompass really all of medicine, that you can focus on. You can also think about whether you want to focus your attention to inpatient or outpatient. And likewise, you can also think about peri-procedural versus procedural. You don't necessarily have to think of yourself as being, the technician, the surgeon, the operator in the room. There's more to IR than just the catheter and the wire, and there's a lot of stuff that happens before and after the procedure that you have to be on top of, and that is affected by COVID. And then, of course, you want to establish what your outcome is. And so you can define your outcome by the clinical endpoint. So it could be the efficacy of your treatment. It could be patient satisfaction. You can think of more cost effectiveness, and that's a big component of a lot of biodesign projects that have already taken place. And you can measure cost effectiveness by maybe how efficient you're able to turn around rooms, maybe how fast a particular procedure may take. All of it ultimately is sort of efficiency and effectiveness of that procedure. You can also think about it in terms of safety. So obviously you want to help patients and treat particular diseases, but maybe you're going to focus on minimizing adverse events. Obviously, with this particular theme of COVID, you can think of minimizing adverse events as maybe being simply eliminating the COVID or minimizing the COVID exposure risk in various stages of an IR workflow. So the key thing here to remember, is that identifying the problem is the first and foremost thing that you have to deal with to really be successful in this whole process. And that does require a thorough understanding of the unmet clinical needs. So I may rehash that statement over and over the next coming minutes, but really before you embark on your process, your biodesign process, and try to come up with an invention or solution, you really have to become an expert and you really have to thoroughly understand the problem at hand. Now, finding that problem or the needs finding aspect of it, you may think that, well, you are, I don't know what everyone's level of training is. Maybe people are medical students, maybe you're an M1, M2, M3, M4, or maybe you're an R1 or 2. I'm not sure what level you guys are in your training, but you may think that since you haven't been a practicing interventional radiologist, maybe you're not board certified, maybe you haven't practiced as many years as myself or anyone else has, but it almost in some ways is a benefit that you guys haven't. And I think that inexperience doesn't mean that you have no perspective. I think it actually means that you guys have a fresh perspective. It's something that you guys have that no other interventional radiologist who's practicing does have. And without that fresh perspective, I think a lot of times new things aren't created. So, just to give an example, I guess, a common thing is, taxis, and now there's Uber, right? If you had asked someone like me, 10 years ago, is there a better solution to a taxi? It just wouldn't have even thought of it. I mean, if you want public transportation, it's either taking the bus or the subway, or you hail a cab. But there's another way around it, and that required someone with a fresh perspective and thought, well, there's got to be a better way to do this, or why don't you think of X, Y, or Z? And so I want you guys I want you to approach the process not being ashamed or embarrassed of whatever inexperience you have, and think of it as really an advantage that you have a fresh perspective. And I want you to be able to critique every aspect of a situation and ask the basic questions and ask, why are you doing it this way? So when you're coming up with your needs or your problem that you're trying to solve, I want to emphasize for you guys not to just, imagine yourself in the angiography suite. I know that's kind of a common thing. All right, I'm scrubbed up. I'm wearing my lead. Got my goggles on. I'm in the fluoro suite. What can I do to make something better? IR is more than that, and I want you guys to think about the full cycle of care. So that means, from the moment the patient, maybe when they're at home, to making an appointment with the physician. Maybe that means once they made the appointment, how do they get to the hospital? How do they check in? The process they have to do to come into the clinic room, for example, or maybe it's going into the prep area before they go into a procedure. And then through the procedure itself, and then on the back end of it as well, what happens afterwards, when they're recovering, maybe they're at home, follow-up. So don't think of just procedure itself. I want you to think of the entire process. So imagine things from start to end, the entire cycle of care. The other advice in terms of, needs finding is simply to observe. So the best way to identify problems is just to not even say a word, just kind of watch from outside or just stand in the corner and just see what's going on and try to figure out what are the bottlenecks. What seems to be the trickiest part of this procedure that's going on? What's the holdup here? What's the concern that the nurse or the tech or whoever the physician is having in that room at that moment? So think about all these things while you're simply watching and not even asking any questions. Once you've completed the observation part of it, then the next step is to actually question the dogma, question why they are doing certain things that way. And this is one area where I really think that you guys, with your fresh perspective, can be a lot more effective in biodesign than someone like myself. I may see a certain procedure and I think to myself, oh, well, I do X, Y, and Z, and this is what we do. If I have a patient who has liver failure and has portal hypertension, I put a TIPS in. It's just simply A to B to me. But to you guys, you might think otherwise. Well, you might want to think, well, why are you doing that? Why aren't there other veins or other things that you could consider cannulating? So I want you to look outside the box and don't just look at the textbook answer. Question what it says in the textbook. Think about why it was done in the first place. Don't even worry about that, but think about think about it. Is there a better way to do it? And then the other important aspect to needs finding, I think, is seeking diverse input. And so, just like it's not the important thing of just being in the angio suite, it's also not just the important thing that you're the physician. There's a lot more moving components to interventional radiology than the physician. Think about what the nurse is doing, both the charge nurse and maybe even the scrub nurse, or maybe just the sedation nurse who's in the room providing sedation. Think about the tech, maybe the one who's scrubbed in assisting, and thinking about maybe the tech who's the runner and getting supplies. Think about the transporter who is taking the patient to IR or back to the floor. Think about the environmental services person who's having to sanitize the room after or before the procedure. Think about the supply chain staff and how they're able to make sure the equipment is provided. And of course, never forget the patient themselves. So once you've thought about some of these problems and done your need finding, you're going to want to validate every need. And the way you validate it is by more observation. So if you see a certain problem in one scenario, maybe go to another scenario and see if that still holds up. So for example, if you scrub in with one particular attending and you notice that they do a procedure a certain way, note to yourself the things that are problematic or that are bottlenecks, but then watch that same procedure being done by another physician. So do more observation, or maybe go to a different institution and see how their room is set up. So more observation. Next, you want to talk with the expert. So maybe after watching these procedures, maybe after immersing yourself in those environments, then start asking questions. Ask, why did you do that, and then why not Y instead of X? So start asking questions and pick the brains not only of, again, the physicians, but also the other people who are in the room or other people who are involved in patient care. Then, of course, you want to do your own research. So go to PubMed, Google search even, just look up information and try to figure out, try to learn as much as you can about that particular disease process, the solutions that have been presented in the past, the problems that have come up with, that have come up and how people have solved them. So do your research. Once you establish, maybe a list of needs and different problems, and you're going to start developing different need statements, and you're going to come up with a complete statement with the problem, the population, as well as sort of your objective in terms of what you want to have solved. And as you're learning more and more about the problem and immersing yourself in this whole process and becoming the expert in that problem, you want to constantly modify and sharpen the need statements that you're making. And as you do that, you'll end up developing, dozens, if not more, various need statements based on different things you've observed. And you'll slowly not only start to sharpen and perfect these need statements, but then you'll also sort of develop a narrative. So to go back to the water balloon fight kind of analogy I was getting before, you could simply say, okay, I want to find a better way to make a water balloon. Well, that's great, but if you present it in a more, in a better narrative, you can sort of present the project with more. It'll provide you with more detail, essentially. So you don't just want to create more water balloons to get back at the bully who's been throwing water balloons at you. You want to be able to say that, all right, this person's been ambushing me, around the corner after I leave, the gym, or maybe it's at a certain time of day, and I'm never, I can never expect it. I'm always wearing my, my favorite, clothes, or my favorite jeans, and it always get wet. So as you develop these narratives, you'll start thinking of details that will affect how the product or the invention that you want to ultimately end up with. That will, as you develop your narrative, you end up creating these criteria. So you want to be able to maybe have clothing that repels the water. Maybe you want to have a shield that prevents you from getting wet. Maybe you want to actually just make more water balloons so that you can prevent the person from ever attacking you with the water balloon again. So again, having a more detailed story will actually help you ultimately create a better need statement and help you in your journey in the biodesign process. Once you've created all your need statements and perfected multiple of them, then you're going to want to sort of compete them with each other and see which one is the best. And ultimately, ideally, in an ideal world, I should say, you want to pick the need statement that's going to lead to the most significant change in patient care. So you may find 10 different problems and solutions that you want to provide, but you want to think about which one's going to be the most impactful or the most significant. You want to focus your resources on that. So that's really kind of all the slides I wanted to talk about. Now, the rest of the presentation was I was going to kind of go over some of my own thoughts on the theme. And the theme I know for this year is IR in the era of COVID-19. And I think COVID is something that, unfortunately, we're all being affected by it. But that also sort of means that you guys understand maybe more of it than maybe some other issues that are very specific to IR. So you have a little bit of a leg up there, but the application of COVID and IR is something unique, and maybe we can talk about some of those things. I know the organizers of the webinar put together a PDF or a handout, and I looked through it, and these were the topics that they sort of came up with to initiate discussion or ideas among the people participating. So telehealth, we'll go through all of these in a second. I kind of just summarized each one of these in a slide subsequently, but I can talk about some of the ideas that I came up with. So when I was first presented with this topic, so when I hear of COVID-19 and IR, just giving you my own perspective as an interventional radiologist who has had to adjust to things in the COVID world, the first thoughts that I came up with were, clot. So we know that there's an increased risk of clot formation in patients who are suffering from COVID-19, and obviously IR is one of the premier, if not the premier, specialty to address clot burden in patients, whether that's DVT or PE thrombolysis or clot elsewhere. Maybe it's in a dialysis population, and you're having your end-stage renal disease patients develop clotted grafts more frequently. So that's sort of one of the first ideas that came to mind. How can we address that? Another issue that's come up in my own practice is screening patients for COVID. So, we have patients that, we have to get back to essentially a normal, and we have to treat patients. They have multiple diseases that they're suffering from in spite of COVID, and we have to figure out a way to screening those patients before they come in, because we want to make sure they don't spread the disease. And of course, they get treated themselves, but also that they don't, get infected themselves. A lot of different, moving parts to it. So how do we screen a patient to make sure they're COVID negative before you can bring an outpatient in into one of the angio suites or into our clinic? So this has been a challenge for us, and the solutions that we've had have been in some ways very arbitrary, and I don't know if they've been really great, but if there's a way to figure out how to properly screen patients, that would expedite workflow. Another issue is sort of the staffing model. one of the things that we've dealt with, and I'm sure many of you guys have seen at your own institutions, is people in the IR team, whether it's physicians, nurses, techs, whoever, getting sick, or maybe they're getting exposed to someone who has COVID, and they end up having to quarantine themselves. Well, if everyone is quarantined at once, there's no one to do the procedure, and there's obviously a need for IR procedures on a daily basis. I mean, frankly, for us, we didn't go far below maybe 60 or 70% volume, at the peak of COVID here in Chicago. So IR was always running, and fortunately, we weren't decimated in terms of staffing, and we were able to keep things running. But you have to think about how you're going to manage staffing when staff does get sick. Another issue that has come up with us is how we set up our angio suite. Our angio suites, for example, in our hospital, which was not that old, it's only built about 7 years ago, but we don't have negative pressure rooms, and so that's not necessarily a deal breaker in treating COVID patients, but it is recommended. And how do we manage treating patients when you don't have negative pressure? Well, the solution we came up with was having negative pressure anteroom. So there's a door, there's 2 doors to enter any individual angio suite, and so we had to have an anteroom, sort of like a makeshift room with, as you might see with like construction that might be going on in a hospital where they have negative pressure and suction. And so you walk into the anteroom, close the door behind you, and then open the door to go into the actual angio suite, and then again close the door behind you. So there's sort of a suction, not necessarily in the procedure room itself, but through the doors to prevent any COVID from escaping into the rest of the work area or the rest of the hospital. But again, that was one workaround to the solution of not having negative pressure rooms, but maybe someone could come up with another solution to that. Another issue that that I've always thought about, even before COVID, but with TB patients, is how do you deal with transporting patients who are on isolation through the hospital? Patients are put on, they wear masks sometimes during transport, sometimes they actually don't. When they come down to our holding bay, they're put in isolation rooms that maybe are negative pressure, maybe they're not. Sometimes hospitals don't have the facilities to even have a holding area. Maybe traditionally you're just sort of waiting in the hallway before you come into the actual procedure room. What do you do about going in the elevator up and down several floors from the patient rooms down to wherever IR might be located? How do you prevent COVID transmission in those closed spaces? So there's a lot involved in sort of this non-procedural aspect of patient care. And another thing that's come up in our own practice is the decline in elective case volume. And it sort of goes back to how you screen patients for COVID. But is there a way for us to treat patients maybe either outside the angio suite, or maybe there's a way to properly screen patients and let them know that there's a safe alternative to being treated, maybe without being exposed to other patients, and let them know somehow that they can have an elective, fibroid embolization, they can have an elective prostate artery embolization, things like that that technically can wait, but certainly that are life-affecting ailments, and that people want to be treated even during this time of COVID. So those are some of the things that I thought of when I first saw the COVID theme, and I'd be more than happy to engage people in the discussion of those ideas. But the other topics that were discussed, that were discussed by the organizers, telehealth was one thing. I won't read everything here, but this was in the handout that was provided by the Biodesign group. And so now that telehealth is obviously an important part of what we do, how can we get more information from patients when it's virtual? Obviously, you can't do a full physical exam. Other devices you can use. Think about the example they gave here was the iPhone-based devices. Maybe there's a Apple Watch type thing where you can get vitals without necessarily having the patient be in front of you. These are all important things that affect IR that again they're not in the angio suite itself. Another topic that was brought up was how can we implement social distancing in IR? There's different ways you can think about this. Maybe there's different room setups you can consider. Maybe, you know, one idea that was brought up in the handout was, can patients be treated without even having to come to a hospital altogether? There are ways we can do home IR. So these are all, again, ideas and things that maybe you guys can contemplate in your mind and maybe come up with different ideas. Another thing is, you know, again, can you do IR, you know, closer to home outside of the IR angio suite? It seems a little bit far-fetched at first, you know, thought, but again, this is one of those ideas where if you really play with it, there may be solutions that utilize imaging guidance to perform procedures, you know, in home. PPE, I think I kind of already discussed this in my own, you know, thought bubble in terms of things that came into my mind. But you know, how do you efficiently utilize PPE? Again, something that doesn't necessarily affect IR, but a lot of physicians. Other things that can be done without human interaction that can avoid the need for PPE, decreasing contact points, you know, between patients and different providers. And accessing IR in I guess urban areas is the term that they use. But again, this also refers to maybe, is there a way to do house calls in IR? Again, it might seem, you know, to someone like me, might seem, you know, preposterous. How can you do IR at home? But it's something that maybe you should try to tease in your own mind and see if there's a way that you can figure out a very novel solution to solve a particular problem. And another idea that was innovation to practice. You know, how do we reach patients during a pandemic? And this sort of is more of a global idea, not global, but an idea that spans not just the COVID pandemic, but you know, how do we reach patients and let them know that there's IR procedures that can be done in general, but specifically during COVID. You know, there's a lot of surgeries, for example, that maybe, you know, are canceled. So an elective cholecystectomy might go to a chole tube instead. And so how do you let a patient know that can be done, or how do you let referring providers know that that's an option? So again, so another example here is, you know, that what they call the novel approach. You know, how can we utilize IR and make up for what other procedures can't be done, whether it be in the operating room. You know, so like a lot of our operating rooms were closed during the peak of COVID here in Chicago, and a lot of it had to do with the fact that intubations were considered a high-risk procedure for exposing staff, and so procedures that could be done under moderate sedation, which doesn't require intubation, were preferred. So a lot of procedures were coming to IR, but you know, think about different ways that procedures can be done outside of the OR. And again, this also kind of goes to the idea of, you know, letting patients know that there's different or better ways that we can do things in IR. But again, another way, another idea or something to think about when you're coming up with needs to solve with this biodesign challenge. So those are kind of all the slides I have. I know that I hope that was helpful. I really do. I know I apologize if it wasn't. I'm by no means a biodesign expert at all. You know, I think that I sort of got asked to give this talk more so because I offered a lot of good suggestions for topics that could have been chosen. But of course, this year it is going to be COVID-19, which I think is a very apt decision to go with, given that it is affecting everybody, and I think that a solution would be very much in need. But I hope that the discussion so far helped you guys and gave you kind of an idea of, you know, how to proceed with developing your biodesign project. And maybe the rest of the time we can just kind of focus on addressing and answering questions, and I'm happy to answer questions related to the things I presented. So again, thanks for giving me the time to talk.
Thank you so much, Dr. Navuluri. That was great. And, you know, going through all the different prompts, I know is super helpful, and I'm sure everyone else thought so as well. So if you guys have any questions, feel free to throw them in the chat and I'll relay them back to Dr. Navuluri.
If there's some way to even unmute you guys, you know, I'd be happy to do that as well. You can always ask me any particular questions. it doesn't necessarily have to be about the biodesign process. You know, you can sort of pick my brain as if I'm, you know, one of the, you know, if you're observing, I know I said ask the experts, you know, you consider me an expert, maybe even ask me what things that I might not have presented on the slides, maybe things you noticed, and maybe pick my brain about ideas that maybe you have in terms of projects. But if there are no questions, that's fine as well. I'm more than happy to answer anything by email. It's a really easy email. It's just ir@uchicago.edu. So feel free to shoot me an email that way. Happy to, you know, have you guys bounce ideas off me and help out in any way I can.
Yeah, if you guys would like to, for me to unmute you so you guys can ask Dr. Navuluri a question, just shoot me that in the chat and I can do that. But in the meantime, if you guys could fill out this post survey, it'll also be sent to you later, but in the meantime, if you could fill this out, that would be great. You can scan the QR code, and again, it'll be sent to you guys later too if you aren't able to. Okay, Dr. Navuluri, we have a couple of questions for you.
Definitely.
So, actually, I think what probably will be best is if I just unmute them individually. So first, I'll start with Apurva. Let me unmute you. All right, Apurva, feel free to ask your question.
Thank you so much for this webinar. It was very helpful and insightful as well. My question would be, can you please show us the slide that you told us after the telehealth? That was a very informative slide that I could not check. After telehealth and before outside the angiography suite.
Was it this one?
Yeah, sorry, one sec. No,
Oh.
Dr. Navuluri, let me just switch back presenting mode to you. Great.
Was it this slide?
Yeah. Yes, that's correct.
So actually, so everything that's written here actually was taken from the PDF, or I think it was a handout of sorts that was actually given to me, and I think it was meant to be distributed to all the SIR RFS attendees or people who are interested in the biodesign project. So I'm sure the organizers can forward that document to all of you guys, and it'll help you guys come up with different ideas.
Sure. Thank you.
Okay, and another question we got is, Lindsay says, thank you for the talk. For questions on technical expertise, who could we reach out to for testing idea feasibility?
Oh, there's plenty of people, honestly. I think that, first off, I think I don't know of any interventional radiologist in SIR that is not open to, you know, students and residents to ask questions. I mean, I think one of the great things about SIR is that everyone loves to teach. I really have met very few people that don't enjoy it. So I honestly think you could reach out to pretty much any SIR mentor. I know that there's a mentor match feature, for example, on the SIR webpage that you can use. I'm one of the mentors for what it's worth. You can always reach out to someone through that route and just pick their brain. It could be an attending at a hospital that you rotate at or that you work at, or if you even just want my own personal recommendations, if you let me know, if you just shoot me an email, or you can ask me now, I suppose, even what location you're in, what city, you know, I can try to come up with some people that I would recommend, and I know for a fact that they would be happy to help you guys out to bounce ideas off of. But I'm more than happy to. I'll volunteer myself first and foremost to help out with any ideas you guys might have. And now is even a good time if you guys want to, but up to you.
Great, thank you so much, Dr. Navuluri. Now I'm going to unmute Vraj to ask his question. Raj, go ahead.
Hi, Dr. Navuluri. Thank you for the talk. It was actually very helpful. My question is a little bit targeted towards one of the prompts. One of the prompts that was handed out was that basically to find a surgery that doesn't currently have an IR correlate and sort of like design a procedure that could replace it, that can be done through like image guided means. For that, what would that really entail? Because I doubt we can like, you know, go into like large animal studies and actually test it out. Like what would be a good like proof of concept for something like that?
So, you know, I wasn't the person who came up with that specific like suggestion, and I know that really that's a challenge in general that we want to try to address as interventional radiologists, even outside of COVID, right? So I think that that's a very grand plan. In fact, that's a lot of what IR is coming up with solutions outside of what they do in the operating room. I think the challenge probably for this particular you know, biodesign challenge is going to be finding a way that it applies to COVID. And I think in my opinion, the best way to think about it might be to approach surgeons and see what they have not been able to do as frequently because of COVID. What have they been limited in doing? And I don't know that specifically off the top of my head. I know that just the example I gave earlier about cholecystectomies, I know those at our hospital had been sort of canceled essentially, and all patients were required to get a chole tube. Likewise, patients who you know, might have had a gastrostomy tube placed in the OR, every single one went to IR to have it done. Vascular procedures that the vascular surgeon may have done, again, they're used to having things done in the operating room with anesthesia. They were all coming to us in IR, and we were doing it endovascularly. So I think the question might be better tackled by you guys, not necessarily coming up with an entirely new procedure, but coming up with a way to emphasize or to streamline the protocol to address existing surgeries that already can be done by IR, but kind of emphasizing how they are better done by IR. I don't know. But to create an entirely new procedure, again, I don't know if it's really specific to the COVID theme that was proposed, right? Because you're always trying to come up with new ways to do things that are traditionally done in the OR. So for one thing that I like doing, for example, is endo-AVF creation, where we use, you know, the magnets to create AV fistulas rather than having open surgery. That's something that's you know, it's been in the works for many years, and it doesn't really necessarily tie directly to COVID, but it's definitely a challenge that was overcome. So I know I probably didn't answer your question the best, but again, my main advice would be to try and tie things to COVID specifically, if at all possible, if you're really trying to sort of win the challenge.
All right, thank you. Our next question is from Hassan, who asks, could you please explain a bit more about how to go about researching a clinical need and becoming an expert, especially if it's something that might be related to peri-procedural care?
Yeah, I think the first step really is going to be observation. So you just have to identify it and see it for yourself. So, and maybe you might not identify the problem. Maybe by observing, you're not going to notice that something is going on, but you may watch a nurse place an IV in a patient before a procedure. And you know, you may ask yourself, or you may walk up to that nurse and ask him or her, why did you even place that? You know, why did that take you know, a little bit longer? It looks like you're a little bit frustrated there. What could have made that easier? Why did you do that before the procedure? Why didn't you just wait till we brought the patient into the procedure room and do that then? There's lots of different questions you could ask and just kind of challenge why things are done. So I know that becoming an expert is difficult, but the first step is just kind of identifying the problem, right? So once you identify, well, okay, we're placing IVs in the holding area, and that's exposing staff to COVID, and it's just delaying patient care. Then you can probably research, the protocols involved in IV placement. Who's trained to do that? What techniques are being used? What devices are being used to do that? And then slowly sort of delve into kind of becoming an expert in that one particular area. So I know it's hard to become an expert on everything in the whole process of patients coming through IR, but I would definitely start with observation first, and then pick the brain of some people who you're observing, and then start researching it. Don't take what they say as perfect or as the word or the answer. Just accept it and then go home and start researching and see, is that true? Is what they said to me correct? Is there any data to support this? Has anyone tried something else before? So it's a process to become sort of the expert.
Great. And we have a similar question that kind of follows up on that. You mentioned that a way to identify needs in IR is through observation. However, in this situation where students can shadow or are in earlier years of medical school, how do we observe? And that's from Sana.
Yeah, that's a great question. So obviously, in our hospital, for example, we are allowing our own home students, like at University of Chicago, we have our Pritzker medical students, so they're allowed to shadow us, but we don't have visiting students. But presuming you're a student who's at an institution or medical school that doesn't have a home interventional radiologist, I do agree that can be a bit challenging. One idea off the top of my head would be to maybe watch YouTube videos. So I know that there are multiple procedures that have been videotaped and have been presented, and you can sort of try and watch and see what people are doing. So that's one solution. If you can't watch a recorded observation, then observation honestly might be sort of out of the, it might be, you might have to go to step 2, which is simply interviewing, experts or interviewing people who are involved in patient care in IR. So maybe instead of watching a uterine fibroid embolization, maybe you'll simply call up and talk to the charge nurse in IR and ask them about different aspects of scheduling or different aspects of patient prep before the procedure, follow up, or maybe you'll talk to the resident or fellow, no more fellows, but resident or attending, and ask them, if you notice any issues with your UFE patients. So I do agree that observation is going to be difficult in the era of COVID. If there was a way I could share my feed with you guys, that we have cameras in some of our rooms, and the feed goes to the attendings to allow them to monitor cases. If there's a way I could share that with you guys, I would love to do that. But obviously with HIPAA issues, we can't. But short of that, a lot of it's simply going to have to be through recorded videos and skipping that step and going to discussion with experts and reading about workflow. But again, just to throw this out there too, if you are in a particular city or location, feel free to shoot me an email, and I can try and do my best to find someone local who might be willing to either not only talk with you, but maybe even let you shadow them, and maybe the rules are lax at that particular institution. It's worth a shot.
Okay, thanks, Dr. Navuluri. And then we have one last question from Payush. So his question is, this isn't COVID related, but what do you think about disposable AirPod type headphones that patients can wear for lengthy procedures so that they can listen to their own music, audiobooks, etc., to minimize restlessness, but can be turned off at times by the physician when needed?
I think that's a cool idea. I like it. I don't know if I've seen that done before. I'm trying to think. I know that I want to say there's a somewhat similar idea for PEDS patients to help distract them when they're getting like scans done, like MR or whatnot. I'm not sure if it's MR, maybe it's CT scans or whatnot. I know I've seen with the MR scanner, but I want to say there's a similar idea has been thought of. But I think for, it's a great idea. I think the key, as I apologize, I don't remember the name of the person, but the key, as that person mentioned, is sort of being able to turn it off. Because there are times during moderate sedation that you do have to wake a patient up or make sure, maybe they're not breathing spontaneously. You want to sort of see if they hear you and if they're awake. So you do have to be able to turn it off in a sense. But it's a cool idea. I like it. Definitely worthy of investigating further. If I had to critique it, the only thing might be is, how does it apply necessarily to COVID? But that's a separate thing. But I think as an idea in and of itself, I think it's a very cool idea.
Great. Thank you, everyone, for all your amazing questions. And again, thank you so much to Dr. Navuluri for, great talk and really engaging discussion as well. If anyone has any further questions, related to the biodesign competition, you can feel free to reach out to anyone on the biodesign committee. And if you have any further questions for Dr. Navuluri, he shared his email with you guys earlier. But yeah, if not, thank you so much for coming out tonight. We really appreciate it.
Thank you.